This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Sleep Medicine Update for 2014, to Infinity and Beyond. Upon completion of this AARC webcast, participants will be able to differentiate between in-lab studies and in-home testing, discuss the current issues affecting in-lab studies and in-home testing, identify new developments that will affect in-lab sleep studies and in-home testing, identify the role of the respiratory therapist in sleep medicine in the context of the current healthcare environment. I am pleased to welcome Ms. Karla Smith. Karla is a registered respiratory therapist and a registered polysomnographic technologist. She is the Sleep Center Coordinator at St. Alexius Medical Center in Bismarck, North Dakota. Karla is also the AARC Sleep Specialty Section Chair. Neither Karla nor I have conflicts of interest related to this presentation. Any use of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Karla, welcome to the program.
Thanks, Shauna. Glad to be here. First of all, I just want to make sure everyone can hear me, so can you put your hands up and let me know you're out there? Awesome. Great. It's just weird for me that I can't see you. So, and Shauna told me it'd be weird. So, again, glad you all are here. And so we're going to talk about sleep medicine and why did we pick to Infinity and Beyond? Well, it's because the sleep industry is always changing, and we need to be ready for that. And as respiratory therapists, we are used to that. We're used to adapting. So just a couple things to start out with. Just so you know, I'll be using HST or home sleep testing, and this will encompass everything, you know, including out-of-center sleep testing, portable monitoring, and in-home studies, just so you know. And of course, I am by no means an expert, and I'll do my best to answer your questions, and if I don't know the answer, I will look it up and I will get back to you. Okay? So let's get started. And how many of you work in sleep? Can you put your hands up? Great. Great, great, great. Okay. Just a second. Okay, so let's get started. So you work in sleep, you know what polysomnography means. That is our in-lab testing. And of course, it's derived from the Greek roots poly, somno, and graphy, meaning right. We have multiple channels that we're recording during the night, of course, to make sure we know what that patient is doing during their sleep. Patients are observed by trained staff to assure the test is clean and accurate, and also to make sure that if there is any intervention that needs to be taken, that is taken at the appropriate time. The in-lab study indications were updated by the ASN in 2005. And then, of course, we know that the RT to patient ratio is 1 to 2, maximum during testing. And I think there was a brief time where it was 1 to 3, but I think most of us that work nights had a fit and decided that 1 to 2 was pretty okay. And of course, that patient ratio is, from my point of view, that way because it's for patient safety, as well as to make sure that we, you know, do the right thing by that patient, making sure we recognize that there's issues and we recognize that intervention needs to be taken. Okay. So here are the indications for the in-lab testing, and of course there are a lot. And of course, you know, the observed apneas, you know, that's definitely going to get that patient in there. And all these other things going on with this patient. And when we look at this list, we can see why we need to see these patients in the lab, especially if you're looking for patients that have moderate to severe congestive heart failure, stroke, significant arrhythmias, that type of thing, but also to reevaluate those patients who have some type of therapy going on, and also to make sure that they really do need to be continued on PAP therapy. When we look at the AHI, of course, we would consider anything greater than 5 as being abnormal, but what the guidelines state and is that the AHI greater than 5, or greater than 15, sorry, excuse me, is a shoe-in, really, for CPAP, but also AHI greater than 5, less than 14, with symptoms of excessive daytime sleepiness, mood disorders, or insomnia, hypertension, or history of stroke would need to be treated with CPAP. All right. So then we go on to home sleep testing. And I think this is where most of our, most of us are going to have questions about this. I know I do. But of course, home sleep testing, of course, is not done in the lab. It's done everywhere but. And obviously, due to the fact that there's no EEG, we don't get to review the stages of sleep and, of course, the actual measured sleep time. Some of those home units give us a pretty good idea, but we really can't measure that actual total sleep time. Patients are instructed in the use of the equipment, but of course, we all know that if you're going to instruct someone on the use of a piece of equipment, the technical accuracy is only as good as your instructions and as good as that patient understands your instructions. And we know that for some people, once they grab this medical device and they take it home with them, it can be an overnight oximeter, and they still really have a difficult time with that. And so for your home sleep testing, of course, the major portion of getting a good test is that technical, is it technically sound? So really, we really need to instruct our patients on how to use that. And also, if you're working in a lab, important to have someone on call to do that. Okay. Of course, if you're looking at our patient ratio in the lab, as opposed to the patient ratio doing home sleep tests, one RT can prepare and record, if you really look at it, 3 to 4 times more home sleep tests than they could an in-lab test. And it makes complete sense. And then the indications for home sleep testing were established by the ASM in 2007. The problem with a home sleep test is that if you test a patient who's at high risk for OSA and the test is negative, or the technical quality is questionable, you get to do it all over again. And you have to eat that cost. There's probably, again, not very many places that are going to do that. I will tell you, where I am working, we are not doing home sleep testing at this time. So I look to you all. If I'm totally missing something, just let me know. But again, we've done very few, and they've all been technically sound, but I'm waiting for that time when it's not, and then we just have to do it again. Okay? So here are the indications for a home sleep test. And really, it's the ones on the left. Those patients need to have, if they meet those 4 signs, they really could get by with a home sleep test. Okay? If you're looking at the right side, these are reasons why a patient should not have a home sleep test. Really important. And there are obviously guidelines for home sleep tests, and since the home sleep testing seems to be all the rage in some places, I'm hoping that the providers, not the providers, but the payers realize that not everyone should have a home sleep test. And I always say a girl can dream, because these guidelines are out there, but is the insurance payer really going to pay attention? They're looking at bringing down those costs. And we'll talk a little bit more about that later. And of course, no peds patients. I don't know how many of you out there do pediatric patients, but you know that in order to get a really good test, they need to have probably end-tidal or transcutaneous CO2. And as much as our rep would tell us that our units can be used on a pediatric patient, we tell them no. It's not going to happen. So here's a little slide on reimbursement. And I guess I didn't go back and look and see, how much, since I've been doing this for 10 years, how much it truly has decreased. But in the last year, and these are numbers from CMS for 2014, how much those reimbursement numbers have decreased. Home sleep testing, by far, and it's not like you can, make it go any less. I mean, you don't want less reimbursement for a home sleep test, but that has come down 6%. And our in-lab PSG is 4%, and our PAP titration another 4%. And those in-lab studies can be a lot of work sometimes. Sometimes they're a breeze, sometimes they're a lot of work, and you get a lot of great data from that, but you also want to make sure, you can pay the bills. So anyway, I hope that is helpful to you, but I think that this slide says it all. This slide says that, the payments are decreasing, and what are we going to do about it? What can we do? We'll discuss that too. So another thing we need to address is, the home sleep test costs. If you're currently not doing this, then you have to think, is it worth it? You have to look at, what your current business is. If your sleep lab business is decreasing, is it because there's home sleep tests, and these home sleep tests are being done by outsourced companies? So you really need to look at what is the cost, the startup cost to enhance your home sleep testing program. And if you're looking at, what type of unit, are you going to own it? You're going to rent it? What are you going to do with it? How much in-lab revenue are you going to lose once you're doing home sleep testing? And who's going to order these tests? Is it just going to be your board-certified sleep physician? Are you going to take direct referrals? What's going to happen there? How much education are you going to have to do on those, or for those primary care providers who will be ordering your home sleep tests, just so they know that they can't just put it on everyone? Okay? And then what are you going to do? If you're not going to do it yourself, are you going to partner with someone else? Are you going to outsource? And then you have to think about, how many units are we going to order? Do you start out with 2? Do you get 4? Do you just start out with 1? And how do you pick a unit? There is an ASM guideline out there, and I apologize since I do not have that reference in my slides at the end, but what the ASM looked at was the Scoper method, and they basically did that to weed out the units that they saw were unsuitable for home sleep testing. So Scoper is looking at sleep, the cardiovascular, oximetry, position, effort, and respiratory. And if you can't find that reference, just let me know. I'll be happy to help. Now let's look at the loss of in-lab revenue. If the thinking from your institution is like ours, if we start it, we're going to lose money. That's how, I guess, our docs look at it. I'm looking at it more from a perspective, if we don't do it, we're going to lose money. If we don't do it, we're going to lose our referral sources. And if we don't do it, are we really taking care of that patient? I think it's okay to be a patient advocate in this, because you do know which patients should have home sleep testing and which patients should not. All right, and then you just, again, have to get real with your referral sources. If you have some really awesome referral sources, it's probably worthwhile to teach them, how to order home sleep testing and help them understand which of their patients would do well. All right, so what to do. What are we going to do? So we need to remember that both of these diagnostic tools are used to assure patients are diagnosed and treated in a timely manner. We need to remember that, because our lab is backed up probably 4 or 5 weeks, and if we were doing home sleep testing, we could take care of those DOT patients right away, and they, would be able to get back to work. Or, there are certain patients that it would work for. And the decision, I think, in most instances actually, is just marred by that decreasing reimbursement. I still feel that a home sleep or an in-lab study is the gold standard, and I think we're doing a good service to our patients and being advocates for them. All right, so since we have a headache from all of this, let's just get a bigger headache. So we're looking and thinking about all the things that are going on and the things that are changing, why we're doing what we're doing. So if you look at this slide, you all have seen these. You all know what these are. Pre-authorization, and I laugh at that one because when I started quite a few years ago, we had to pre-auth everything. And in our state, and I had a discussion with the Blue Cross Blue Shield rep, that now we have to pre-auth home sleep testing, but we don't have to pre-auth our in-lab tests. And what I was told is, you know what, we feel those in-lab studies are a better service for our patients. And I just kind of wanted to send that lady a high five, send her a thank you, because she understands it. And sometimes I think most of us feel that our payers don't understand it, but some of them really get it. Okay, so we're looking at pre-authorization, utilization management, and cost containment. Those are all dirty words. I think they're all words that we just cringe at. But the increase of these three has more than likely increased the number of home sleep tests being done, and this we know. However, this is not necessarily a good thing because patient outcomes may be less than optimal. And let me give you an example. Cost containment may be forcing patients to have a home sleep test when their condition warrants an in-lab study and an in-lab titration. And that's where I struggle, is with the in-lab titrations. Let's say this patient has central sleep apnea, so their home sleep test may show that they have mild OSA. And in some areas, rather than bring them in for a titration, so we can really see what's going on, they get put on an APAP. Okay? So, in the case of this patient, the outcome will be less than optimal because if there's no one following up with that patient and they're home on this auto unit set anywhere from 5 to 15 and they have central sleep apnea, what is going to happen? They are not going to wear that, and nor are they ever going to probably come back and have a sleep study again. And they really do need to be treated. Also, a home sleep test on a high-risk patient is technically inadequate. Okay, and so what do we know? If it's technically inadequate, then we have to test them again. And if we test them again and it's technically inadequate or it's negative, and we want to do an in-lab study, that may be denied. So here we are. We have this patient who we know probably has OSA, and they can't be treated because we can't get them in for an in-lab test. Show of hands, has this happened to anybody where they are not able to get their patients in because their home sleep test was negative but they were at high risk? I'm just asking because we have great, really scary. We're working on some OC health issues, and this is one of the things that our OC health lady is concerned about. She knows these patients have to have a test. Thank you so much, you guys, for responding. I appreciate that. Okay, so let's go to the ACA and the PCMH, so the Patient-Centered Medical Home. So, again, the Accountable Care Act and the PCMH focus on quality. Okay, they focus on quality care, which is great because that's what we want to do. The ACA's goal is to provide quality, affordable health care and insurance to all Americans. Great intentions. They really have great intentions. The ACA follows the model of the PCMH, which relies on primary care to provide coordinated patient-centered care. So what we know from this is it's probably going to bolster that primary care involvement, but the primary care providers are already pretty busy. So how do we, how is this all going to work? We have specialists for a reason, but yet we're making sure or really demanding that our primary care providers take care of all these patients. So we need to do something. We have to think of something. And then accountable care organizations. That's the last one we're going to look at. So ACOs are groups that unite to provide Medicare patients with highly coordinated care. These groups save money for Medicare, and they get to share in those savings. Okay, so the formation of ACOs may be the reason many private physician practices are being purchased by medical centers and why there are so many more hospital mergers happening. Okay, because I don't know, in the case of our little hospital here, we just became part of CHI yesterday, and so we did have to merge because we're, on your own, and what are these little hospitals to do, right? And as far as, in our area as well, very few private physician practices. They belong to one health system or the other. So although ACOs, may be a good thing, and I really think it is a good thing, at least for our hospital, but Again, how are they going to save the money for Medicare? Where are those savings going to be, and where are the cuts going to be made? All right. So I think what we need to talk about is we're going to, how are we going to save that money but yet provide quality care to our patients? Can they both happen? I don't know. I think that remains to be seen. But one thing we can, again, focus on is that care coordination, and we know that this is something our payers really, 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 really want. They want to assure that coordination in patients with complex or chronic diseases is there. And in this we know these patients who have chronic diseases, if we don't take care of one, they're going to be back in the hospital, readmitted for that one disease. And if we could get everybody on the same page, we might be able to help these patients out. Okay, they want to streamline the referral processes as well, and that is also important. Global payment for high-value care, challenging the traditional care model, and also transitioning from diagnosis to outcomes, and that's kind of what's happening. If you read anything about sleep, they are moving more towards measuring your outcomes. Yeah, now you have this patient diagnosed. What are your outcomes? Are they compliant? Are you taking care of them? Are they being followed up on a regular basis? Going back to patients with complex chronic diseases, so patients that may have diabetes, OSA, and heart failure, they have a lot going on. And so what these payers are looking for is someone who's going to take care of all of that. So if you have your cardiologist and the doc that manages the diabetes and your sleep doc, they all need to be on the same page. They all need to be able to chat and help take care of this patient. One more note when we're looking at global payment, the CMS Innovation Center is investigating the possibility of a bundled payment model to include care managed by specialists. I'm not quite sure how that is going to work out, but your specialists get paid a little bit more, and how will that bundling work for them? Okay, and again, this is going to require tweaking of the current model. It's not going to be the same. Will it be one big chunk of money, and you have to make it work for this patient, and that includes your specialist? Again, I'm not sure how that's going to happen. One other thing that I did, and I don't know, raise your hands if you've ever heard of the Well-Trinsic Sleep Network. Out in our little area, it's not anything we talk about or have we seen. Great. And because I don't know a whole lot, I would love to hear from anyone who is currently using it or knows more about it. Doing the research, the website doesn't say a whole lot, but here is what I did find about it. And again, it's the only model out there for sleep alone. Okay, so it's an ASM endeavor to provide an integrated care paradigm for sleep medicine. And my understanding is going to connect board-certified sleep medicine physicians and accredited sleep centers to deliver high-quality integrated care. And because my brain doesn't work that way, I cannot see the whole picture. I don't understand it. Again, the only model that's specialized for sleep medicine. And what I could find out as well is they would negotiate for sleep services with insurance companies, sleep benefit management programs, ACOs, blah, 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 which sounds like a really, really good thing. But if anybody has information about that, I would love to hear about it. And I'm going to provide my email at the end, but also on AARC Connect is also a good place to have this dialogue because I'm not, again, quite sure how that's all going to work. And I know for the first year it's free, and then I'm not sure what the cost is after that. All right. One more thing here. So here's the paradigm of care shift, and we all need to be ready. Okay, we really need to embrace home sleep testing. Like I said, as much as the physicians I work with just keep asking me, why would you do that if you're not getting reimbursed? And I say to them, why wouldn't we be ready for it? Because I think it's a service that we need to have for our patients if they do in fact need that. One more thing this shift is going to do, it's going to increase sleep and primary care interaction. I don't know how much of that goes on in your areas. It does happen a little bit here, but it's pretty much here's my notes, and that care coordination kind of seems to get lost. Again, we're looking at emphasis on quality markers. We really, really need to, amp up our quality, making sure that, again, we get paid for that quality, because that's what payers want to do. They want to pay for quality. And then again, emphasis on chronic disease management. And I think that we've been talking about chronic disease management since, I don't know, 1993, and it's just been really, really slow. And it's good to see that at least in the field of respiratory therapy, there's chronic disease managers, respiratory care managers out there that are taking care of these patients. So I think sleep could do the same thing. Again, all my opinion, but I really believe it's something that we can do because we need to do something. All right, so this slide says it all. I think we need to seize the opportunity, and in my upcoming slides, I think we're going to talk about the whole shift that is going on. And I will say, when I went to the sleep meeting in Minneapolis, my eyes were opened. I was, wow, I never saw that coming. So let's just talk about it right now. So what is the future of sleep technology? In 2013, the AAST had a meeting. And they talked about that the regulatory and economic pressures are changing how patients are being diagnosed and treated. And this we know. We've seen that there's decreased labs opening. There's decreased number of patients coming into the lab. And so they saw this. And home sleep tests are the test of choice by payers. And increased home sleep tests may decrease the number of technologists performing in-lab diagnostic testing. This I did not see coming. This, I think, for me, I think I saw it coming, but seeing it in writing, like the technologists performing in-lab studies, the need will decrease. Then what? What then? What do I tell the staff that I work with? Sorry, we're having, not enough people come in here. We're going to have to let you go, or y'all have to go back up to respiratory therapy. Okay, I think they kind of like, what's going on in their lives now anyway, work at the nights. But anyway, so like I said, there's more changes. So again, the models of patient care will focus on education, monitoring, and follow-up. Inadequate number of trained physician specialists, trained sleep specialists. And I think this is happening already. I mean, who wants to go into a specialty where your patient numbers are decreasing, the amount you get paid to read is decreasing, but you're expected to read all these and see all these patients. And I think it's getting a little hard for them to keep, recruiting for sleep specialists. And there is a need for well-trained sleep medicine specialists, and by that I mean people that work in the sleep lab, to help by becoming physician extenders, stepping up to do more than acquire clean studies and score the sleep data. Do you see where I'm going with this? Like I said, when I went to the meeting in Minneapolis, I was surprised. And so I think my takeaway message from that was, this is really bad news for technologists trained only in sleep. And by this I mean your non-clinical people. So when I think about, and I don't know how many of you were around when we were doing licensure, and maybe you're still fighting with that whole thing, but it was, the discussion that was held was, we run these tests, we know what we're doing, all of this stuff. And I'm not saying that to be, one-sided, but it was this big, huge issue. And now what it has come to is, if there's fewer and fewer sleep labs, you're going to need fewer and fewer of those people that just do sleep studies. And all of that discussion that was had, 5, 6, 7, 8 years ago, and may still be going on, is changing. And I actually, I feel kind of bad, because these people, there are wonderful people out there that do only sleep studies, and they're really, really great at what they do. And if they're going to lose their job because now they have to be more clinically inclined and have more clinical background, that could be, a total life changer for them. So anyway, I digress. So again, is it bad news for technologists trained only in sleep? Well, decreasing reimbursement for sleep testing. That's not good because you're going to have fewer and fewer sleep labs, or fewer and fewer people doing them, and who knows, maybe the ratio will be 1 to 3 because, sorry, I know you want this for patient safety, but you're going to only get reimbursed for this. The traditional model for sleep centers may change due to the decreased number of in-lab tests being performed, and that's just kind of what I said before. Patients coming into the lab will be sicker and more complex, requiring those performing the test to have clinical skills to understand the more complex modes of PAP therapy. This is a respiratory therapist, am I right? Okay, so this is what we do. This is why we adapt so well, I think, because we do have this clinical background. Again, these people who are going to be taking care of the more complex patients also need to have more in-depth knowledge of comorbid conditions. And they also have to have quality working knowledge of respiratory physiology and pathology, and that is straight from the AAST. So again, this is probably bad news again for those people who are RPSGTs only. Okay? All right. So long story short, current sleep tests with only sleep potential and no clinical background may find themselves out of a job. And education requirements will increase for those going into sleep technology. So if they're just starting, those things will change. The AST board does agree that in order for sleep technologists to compete in the future of sleep medicine, there will need to be associates as well as bachelor's degree programs. So again, who is the best group to take care of this? Of course, us. And that's where it started. We all started out in the sleep lab all being respiratory therapy, and so I think this is our time to embrace that and really become more of that integrated into this type of model, integrated into taking care of these patients with OSA. All right. I love that slide. Okay. So again, respiratory therapists have all the skills that the AST said that their sleep people need, okay? And so we're already here. Let's embrace it because we have the clinical background. We know how to use these different modes of PAP therapy. We're used to taking care of patients that are critically ill and have chronic diseases. RTs have intense knowledge of medical terminology. Of course we do. We have the skills to educate patients regarding their diagnosis and comorbidities. Of course we do. I mean, that's what we were trained to do. Okay, we could easily promote compliance because, who's that group of people that make sure that those CFers are compliant or those COPDers are compliant with their therapy? Pulmonary rehab staff are making sure that their patients are compliant. And I apologize because this last part should say RTs are already valuable members of the healthcare team, and we are. So when you're looking at another group that's up and coming and learning their clinical skills, and there's this associate's degree, we're already established here. We're already established as a healthcare team. Our opinions and our work is valued. So it's a great place for us. I'm sounding like a cheerleader now, aren't I? Okay, so here's the integrated sleep care model. And I'm not thinking this is the right place for us, but I wasn't quite sure where to put it. So again, primary care providers will be responsible for the evaluation and care of patients with sleep disorders. They're the ones that are going to be ordering those studies. In my opinion, it's going to be the primary care provider ordering the studies, sending them to the sleep specialist to manage those complex patients, or the respiratory therapist or anybody working in the sleep lab is going to be that person that primary care provider is going to go to for a little bit of advice. Can you help me? Physicians. We have a physician's office right across the hall, and one of our nurse practitioners will come in with her download and say, "Okay, help me out with this. What does it say?" And we're being utilized as physician extenders. And I think that's where we need to come in, and I think we're going to be needed. If all this is being shifted to the primary care providers, sleep center staff are going to have to be, have their skills honed about how to read this stuff and how to support that primary care provider in the treatment of this patient. Sleep center teams, the sleep center team needs to integrate with primary care physicians, I can't say that word, but those people, behavioral specialists, and dentists. And another thing is we need, again, to be that group of people that they can go to and ask questions. And we need to know our stuff. Alternative therapies will become standard. So oral appliances will become standard and another form of treatment to take care of our patients. Because if, for me, in our thinking here, if the patient's going to wear CPAP, then an oral appliance is better than no therapy at all. And if you can get them good on their oral appliance, and then, they're pretty severe, maybe you can get them to wear that, and they're needing the CPAP as well, maybe you can get them to do both. I think, we have a good, as respiratory therapists, I think we have a good rapport with our patients, and we can monitor their compliance. Better outcomes and follow-up will be the expectation. I don't know how many of you do follow-up on a regular basis with your patients, but I think it's so important. And especially if you've ever worked in home care, it's really, really important to follow up. I mean, you know that importance, but I think it's going to be more and more expected in chronic diseases as well as, managing OSA or managing those complex sleep apnea patients. Those patients who have complex sleep apnea are sent home on auto SD, and they're expected to just, they're going to follow up in a year. I mean, I think those patients may have better outcomes if we can do more follow-up. Okay, and patient-centered approach to diagnosis, treatment, and compliance will be the standard. We will have to get all of our groups together to take care of these patients. Right. So again, what that means is it means teamwork. And it's just something we're going to have to do and something we're going to have to roll with. Okay. So this actually came, it's a model from Kaiser Permanente Fontana Medical Center, and it was presented, this slide was presented at the sleep meeting in Minnesota, and I thought, how great is this? Because what they're basically saying is, if you're not going to be able, we're not going to be doing that many diagnostic studies, and you're wanting us to have quality follow-up, then, you move those night staff and you have them be these physician extenders or physician support. And if you've ever worked at a home care or a DME, doing a CPAP, that type of thing, you are that physician support. You are already doing that. And if you do CPAP clinics with your physicians, you already are that support for that physician. And that bottom one where I say communicates with the physician occasionally, if you're not in a physician's office, but let's say you do a download and the patient is having a big leak, or they have, all of a sudden their HI is increased, then you're going to call that physician. You're going to say, hey, something's not looking right here. Maybe you need to see this patient. Okay, and then physician extenders. I think we're already there when you're working in the critical care section. So why not when you're working in sleep? Why not have that patient education and provide that for the patient and their family? Communicate directly with the sleep physician. Be able to be on a one-to-one basis with that physician and talk about these patients and what's going on with them. You communicate with primary care providers, but you also be the educator for that primary care provider and their backup. Referring to specific services like dentists is going to be important. And then communicating with patient regarding testing results. I mean, I know in the lab that's a big no-no, but maybe there's a, if you are working in a physician's office, a sleep physician's office, this would be something that you would do on a regular basis. All right. Okay. All right. So this is kind of something also kind of off of what was presented at the sleep meeting, but I thought, again, a really great thing to be able to do with your sleep center. And I don't know, again, we're just a little sleep center in Bismarck, North Dakota, and so, my dream is to maybe move on with some of this. And I think, every sleep center could use this as a model. So if you don't already have a perioperative program, think about it. remote ambulatory program, whether you're providing the home sleep testing for a dental office or a primary care provider who kind of is into the sleep thing. That's something else you can do. Then you have your ambulatory PSGs. You have a case manager. Why can't we be case managers for sleep and do that CPAP follow-up program, CPAP clinics, a weight loss program? Why can't we be helping with that, but also referring to dietary to help these patients out? Again, being that physician extender, having an insomnia program. How about an inpatient respiratory failure program? Anybody have those out there? I just want to make sure you're all out there still, but two, anybody providing BiPAP units for someone in respiratory failure until they can get into the lab or get one of their own? Okay, I definitely want to hear more about that. I definitely would like a discussion about that because I think that's so important. I think sometimes when we talk about it here anyway, or with our physicians, they're like, no, you can't do that. Well, what am I going to do with this patient when we're booked out so far? And they really need to be taken care of. Thank you so much for that. Also, alternative therapy programs, oral appliances, surgical procedures. Do they need to go to that ENT and see what's going on? And way off to the right, prenatal OSA programs. Again, I'm going to ask you all the question, how many of you are doing that? How many of you are doing any prenatal stuff? Cool. Okay. And that is something we've done in the past on our inpatients, but our unit's like 23 years old, and we need to think of something alternative. But why can't that be something that we do out of the sleep center? It's not like these babies need to come in for 12 hours. Okay, we just need to see what's going on for them. Occupational health, again, that's a huge one for us because now we're seeing more and more of these patients who really are coming into the sleep lab because they have a big neck size or an increased BMI. And of course, they're not going to be honest with us and tell us that they're having excessive daytime sleepiness or witness apnea or snoring like a freight train. But this is something we need to think about. And then hypoventilation and complex sleep disorder breathing follow-up program. Again, like I said, these poor patients who have, hypoventilation or they're on auto SV and they're kind of just coasting at home. And I think we need to take care of them because imagine what, their outcomes are going to be. And then, of course, off in the right is the research. And I just feel like sometimes when you're looking for something, there's really not a whole lot out there. Okay. Everybody's okay? Cool? Cool. Okay, so now, where to from here? Well, we need to get out of our comfort zone and use our skills to help our patients because that's what we are. We are patient advocates. And again, I'm going to sound like a cheerleader, but I really think it's important that, I don't think OSA gets enough attention, really. I think patients are, diagnosed with OSA, and I don't know about you, but when I go out and screen patients out on the floors, pretty sure that's the last thing I'm going to find on their chart is their history of OSA. And I think people not realizing how much that impacts someone's disease process. It's to me important, so I'm just a geek about it anyway. We need to be aware of the rules and regulations as they relate to our reimbursement. We really, really need to stay up on this. And also support the ARC PAC to get the HR 2916 passed. I know that's not going to be helpful to a lot of us that are just going to go out and do education, but if you have your COPD educators who are also taking care of those patients who are on non-invasive ventilation at home due to their respiratory failure, that could easily, help them there. And again, never stop learning. Be excited about it because again, again, just don't stop. There's so much out there to be read and so much out there to be learned. All right, y'all with me still? Good, because we are done. And I just thought this was very fitting for today. Never dwell on one obstacle too long, for tomorrow is another day. And again, I thank you for this opportunity, and I would really love to see dialogue continue. And I can be found on ARC Connect, ksmith@primecare.org. That's pretty easy. And you can find me in the phone book, I guess. There are still phone books out there. And then here is my reference list. And if you think of anything else, just let me know, and I'd be happy to help.
Thank you, Karla, so much. We have some fabulous questions in the room, and I'll apologize to the folks out in the audience because I'm going to jump around a little bit with these questions. I want to get some in a block. So the first block I want to address is the appropriateness of those home sleep tests. We have a couple of comments out there about home sleep tests are perceived or may not be the most appropriate thing for patients because we don't have someone there to watch over them and help them with issues and so on and so forth. What kind of controversy has that established in the sleep community?
Again, I'm not probably the best one to ask, and I haven't found a whole lot about that. I mean, we know that it's not the gold standard, I guess. We know that, and we need to, in order for that test to be done appropriately, we really need to educate that patient. But as far as, anything I can see, like I said, of course we know it's not the best test. But I think we're beyond the point where we can decide anymore. I think all we can do is support and then also make sure that our patient, if you call these places and you're looking for prior authorization, it's okay to be that patient's advocate. I know that sometimes home sleep tests can be used on patients who are at home and it's not safe to bring them in here. Those are the patients I worry about because are they really going to understand it? And then the other thing is, if it doesn't work, are you going to get that patient in the lab anyway? Because, I don't know about anybody else's policy, but if we have a patient from a nursing home or a long-term care facility, they have to bring someone with them. And that's kind of cost prohibitive for that nursing home. But, people think that we're nurses and they're expecting us to do all this. So again, are you going to get that patient in here anyway? I'm hoping that answered the question. I don't know what impact there is out there because we do so few of them here. And there's probably other people out there that are way more versed in this than I am as far as that impact of home sleep testing and the appropriateness of it.
Thank you, Karla. Actually, your answer segues nicely into another comment made by someone in the audience who is an RRT working in a skilled nursing facility. She sees a lot of residents referred for a sleep study, and then they're ordered CPAP, but then they're completely non-compliant, regardless of the education that that's been imparted upon the patient. What do you think about the screening as far as compliance goes? Is it, pardon my phrase, but is it a waste of our time to do studies for patients who we can foretell will not be compliant with the prescribed therapies?
I think that's the million-dollar question, really, because we do see a lot of those, and you just feel horrible for that patient. And and again, we don't have RTs working in our skilled nursing facilities, so I'm not sure. I mean, I think that would be awesome, but you can't be there 24/7. And you're doing education to nursing staff, you're doing education to the patient, and are they going to understand it? And I don't want to be crude or rude, but again, sometimes when we see those patients come in here, I'm just thinking, why? Why are we doing that? A lot of times they're confused, and I don't understand it. And maybe that's education for that primary care provider. I mean, I understand that, Mrs. Smith is just not, taking deep breaths, but what are we going to do about it? I mean, at what point are you going to slap a BiPAP on this little grandma and expect her to sleep well? I don't know. I just think sometimes, and again, in my own opinion, there's really, you know what I'm saying? It's hard to get that across. It's just, I think we are wasting our time. I just think we're not going to be able to take care of them. And I don't mean to sound rude, but, I think a discussion here, as with our staff, it's a reality. I hope that helps.
I think so. And some of our I would imagine that most of our audience feels very frustrated, as you do, with that situation. part of the discussion over in our chat room is also talking about how to help compliance. And one of our participants mentioned that for a patient to be more compliant, there needs to be more follow-up visits from the DME, from the home care company, whoever is managing that device, which makes sense. And then another person chimed in and said, that's great, but with the reduced reimbursements, the company is hindered in performing those follow-up visits from the lack of reimbursement. So it sounds as if we're caught in a catch-22. Would that make sense?
Absolutely. And you know, when I always think about the great things that PACT does and how that bill has changed over the years, and just, you know, who knows if that bill is passed and RTs can be reimbursed for more, will it go beyond what it's specifically intended for right now? I don't know a whole lot about the whole government thing, but I'm hoping that once it's, you know, RTs are recognized, then that recognition would go towards payment for services. Does that make sense?
Absolutely. So I have a couple of other questions that are related, but a little bit to another aspect of sleep medicine. We talked earlier in your presentation about who qualifies for a home test and who does not, and we talked about children not being able to do a home sleep test. What about those children who are morbidly obese? Would a home sleep test be appropriate for the older child who has that BMI over 35?
In my opinion, no, because the guidelines state that, you know, and we follow the guidelines stating that anyone under 12 should have end title. Whether they are a 10-year-old that's super obese or a 15-year-old, there's a difference. And you do score those different. I don't know, and again, that's just my opinion, working in kind of a rural area and not seeing a whole lot of really obese kids, and because those obese kids do come into the lab, and you know, I don't know, because they're still children. They may be the size of an adult, but they're still children. Does that make sense? And so I think we need to treat them as not a little adult, they're still a child. And I don't think that home, again, my opinion, they should not be used on these kids who are less than 12.
That makes absolute sense. So one of the comments you made just a few minutes ago prompted another thought. Obviously we have many different areas and types of areas where we have sleep centers or areas where we do home sleep testing or whatever. When we're talking about these home sleep studies, is it, based on your experience in a rural area, is it more likely to be used in a rural area where there are fewer facilities and sleep centers, or might it be more prevalent in a metropolitan area?
I think it's more in a metropolitan area because you have more of those patients who, okay, I have to backtrack now, because, you know, it's twofold. Rural, because we have a lot of patients that live, you know, 200 miles away. So the nearest sleep center, or the nearest town from us that has a sleep center, is 100 miles away. The other one is another 100 miles away. I mean, there's one across the street, but you know, they're pretty rural. And so we could use it in those patients to save them some time, because we're all about that. But then in the metropolitan areas, you're going to have, I would imagine, a backup of patients. If you know that they qualify for a home sleep test and you have all these sicker patients, why wouldn't you use it in that aspect? And if I totally messed up that question, I apologize.
No, that makes absolute sense. Just based on the available services offered and the density of the population. Absolutely. Absolutely. Well, Karla, thank you so much for joining us today for this presentation.
Thank you so much for having me. I really appreciate it.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.